Hello everyone, this is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us for the third in our series of webinars on preventing and managing COVID-19 in the workplace. We really appreciate you joining us today and taking the time out of your busy schedule for this opportunity to get an update on the situation. The session is being recorded and will be available to you within about 24 hours. We'll also be summarizing responses during the question and answers segment and taking questions after the webinar concludes, as we have a limited amount of time and often get a lot of questions. So if you've attended the last couple of sessions, you know that we redistribute the questions and answers in complete format and post it on our website and send it out with the subsequent invitation. So you can watch for those Q&A responses when you get this invite for next week. Please use the Q&A tab function on Zoom to submit your questions, and we will monitor them throughout the session. Our speaker today is Anthony Harris, MD, M.B.A, M.P.H. Dr. Harris is a board-certified occupational medicine physician. He is WorkCare's Vice President for Onsite Clinical Operations and an Associate Medical Director. Dr. Harris has been performing his job recently as our Chief Clinician managing the COVID-19 response. We really appreciate his time and expertise today. Now I'll turn it over to him. Thank you.
Excellent. Thank you, Karen. And thanks everyone for being here today. We are excited to continue to provide up-to-date information in regards to the COVID-19 pandemic, both in the U.S. and abroad, but more importantly, strategies to help combat from prevention to management on the downstream effects on your individuals you're caring for in the workplace, as well as how to manage the return to work process, which we'll talk more about today. So without further ado, we'll go ahead and jump into it. The format, we wanted to be consistent again from week to week. If you're joining us, and hopefully you're joining us in repeat fashion here, we'll get into the clinical update, go over some of the pathology, microbiology, look at the epidemiology, the spread of the virus and illness, talk briefly on prevention, but then focus really on workforce strategies. And with regard to the workforce strategies, we're going to focus in on mental health preventative strategies. So with that being said, we'll go ahead and do a quick clinical update presentation. Last week, we talked about the newer symptom of GI prevalence, meaning people were presenting clinically with nausea, vomiting, abdominal pain, and diarrhea. And we're still continuing to see that trend in terms of increased numbers of individuals. Again, up to 3.5% to 18% of people present only with that as a positive sign for COVID-19. And so we'll see and talk about how that impacts our preventative strategies in the workplace. As we know, many are doing and looking for screening for fever. Obviously, we got to be screening for a little bit more. But what we're also seeing clinically is a presentation of headache become more prominent, and we'll touch on the anomia and hyposmia. These are decreased smell, sense of smell, right? And also associated with that is a decreased sense of taste. And you've probably heard that these are in the news in terms of relevance to COVID-19 infections. And so if we look at the evidence that's being published, and this is 2 articles that are pre-publication in terms of peer review, but they point towards, in this particular study, looking at how many individuals from a Chinese population that presented with positive COVID-19 actually had a presentation of decreased sense of smell and also decreased sense of taste. And up to 80% of this group did have some type of correlation with decreased sense of smell. And if we look at then trying to understand what may be causing this decreased sense of smell, decreased sense of taste, This pre-publication study looked at the pathway of the virus to affect cells in the nose. Two cells in particular, the actual nerves, olfactory nerves for a sense of smell, as well as the epithelium. And it found that while the virus didn't most likely attack the nerve cells directly, the olfactory nerves, it did likely inhabit, if you would, the cells of the epithelium, the lining of the nostrils, and may represent the pathway by which we're seeing this increase in presentation of decreased sense of smell and taste in individuals presenting with COVID-19. Now, there needs to be further studies to show any presentation of only sense of taste and smell decreasing. But again, we need to be mindful of these type of things in terms of our screening. So if we look at real quick what's happening with regard to the U.S. spread, this was a snapshot from last week that we presented. The states you see listed on the right-hand side were the states that were at that time 1 week ago listed as widespread community sustained transmission. Okay, and if we fast forward to today, this map continues to darken. All right, and now the effect of COVID-19 is felt more deeply in far more wide-reaching areas in the U.S. The CDC has updated some helpful links for us in regards to identifying what areas have widespread disease. They've now listed all 50 states and the cases reported in each state, but more importantly, they make it easy to find now a determination of widespread disease, as you're seeing here. So if you access this link, and we can follow up with links to CDC on this, you can quickly identify which states have identified as widespread disease, and that does play a role in regards to understanding who may be higher risk for COVID-19 in the clinical determination of individuals. So when we talk about the pathology of the virus, we spoke last week about the two identified strains, L and S, of the SARS-CoV-2. The L strain being more prevalent earlier in the disease in China that was observed, and the S strain being more prevalent now in terms of disease in the Chinese population with COVID as well as beyond, and the L strain being an older version of the COVID SARS-CoV-2. What we're identifying today in regards to looking at the virus and the pathology, there are some increased efforts to look at not just testing whether or not individuals are positive for SARS, for the virus itself, right? The tests that are on the market are PCR tests, polymerase chain reaction. They look for pieces of genetic material of the virus. And so that's what you're seeing with the nose swabs and the oral swabs, and that's sent off for testing, looking for that genetic material. The turnaround can take in some order of 2 to 3 days, up to 8 days. And so what we're finding now is trying to identify in research as well as in clinical practice, we call it immunohistochemistry, but in short, it's looking at the immune system and the response of the immune system to a SARS-CoV-2 infection, COVID-19. And so we are able to now more and more with a blood test identify those individuals who may have been infected and now have immunity to SARS-CoV-2 because their body has built up that immunity. And so this is an area that is going to have some impact on our return to work functions and identifying who may be able to safely return without tremendous concern for spreading the virus or even contracting the virus again. This particular study is pre-publication as well, and looking at some burgeoning serology tests to help increase the use of this type of observation. And we even see from an immunology standpoint, Mount Sinai and other hospitals are now leveraging a technique used by the Chinese that was successful on very ill patients with COVID-19, and that is using antibodies from individuals who have contracted and recovered from COVID-19, meaning their body has created these antibodies that are now useful if we can transfer them to ill individuals hospitalized in critical condition to help fight off the number of viruses, virons, if you would, in their system. And so again, promising data out of China previously was observed, and now in the US, we've begun to utilize this approach. So if we look at now some of the epidemiology and trying to update where we're at today versus where we were a week ago, obviously you've seen and heard in the news that things are not getting better. They're continuing to get worse, right? And if we look at the global map last week with density per million of population of confirmed cases of COVID-19, the map is darkening, shifting towards higher cases worldwide. And so as we look at the total number of confirmed cases, of new cases, excuse me, so this is the rate of new cases, we're seeing the same phenomenon, darkening of new cases almost worldwide. Again, looking at China, looking at other parts of Asia, we're not seeing that trend continue. If we look at India, we know that the testing in India has not been commensurate with what other countries are doing, so that may be underreported. Yet and still, focusing in on the trend, the globe is experiencing still tremendous increased burden of COVID-19. This map is quite telling in that story, looking at the overall burden heat map of COVID-19. And this picture continues to worsen. We'll look at specific rates of increasing cases as it pertains particularly to the US momentarily here. And again, looking at the map in the US, total number of cases 1 week ago, 54,453. Total number of deaths, 737. As it stands today, that has more than doubled, obviously almost tripled, 163,000 cases and 2,800 deaths. And if we look specifically at a curve that compares logarithmic growth, right, exponential growth of cases, it's really telling because it allows us to see and understand where are we in that that quintessential curve flattening phenomenon that we've seen in China, right? And this depicts a very appropriate but grim picture in terms of our increasing number of cases. It may be difficult to see in the background, but real quick, I'll use my laser pointer here to point out along these dotted lines here, these are the doubling times for cases of COVID-19. So every 10 days, if you're along this line, your cases are doubling. Every 5 days, your cases are doubling if you're along this line. Kind of hidden behind the numbers here. Every 3 days, line is here, and every 2 days, line is here. So in the US, as it stands now, we're on a trajectory that we're doubling the number of cases between approximately every 2.5 days. And certainly that is what we're seeing in the numbers that we're reporting with CDC. So we're, as it looks and appears, we're not close to a flattening of the curve quite yet, right? And if we look at total number of cases, this was a week ago, where we stood in comparison to the world and to China. Today, we can, and then we look also where we were compared to the rest of the world, particularly Italy, South Korea, Iran. We're now past them all, right? We're the #1 geographic for cases confirmed for COVID-19. And if we look at how we're doing with confirmed deaths, we're climbing that as well. This was last week, again, 1 week ago, and this is where we are today. We're only behind Italy in terms of total number of confirmed deaths. This obviously speaks towards the burden that we're experiencing in the U.S. And it also undergirds that we need to continue to push resources towards hospitals, towards the ventilators. And this is why Italy, we know, has had a tremendous shortage of ventilators. They call them respirators over there. For acutely ill individuals in the hospital, right? And so we see that reflected in their number of confirmed deaths. We're number 2. If we look at the fatality rate at its particular countries, we can see that the United States actually is, if you can dare to say, not doing too bad. This is just showing you how we fare with case fatality rate in the United States. This may speak towards our readiness, so to speak, in the hospital and ICUs, but again, with our growing number of cases, this picture is going to change most likely very rapidly as we outstrip the capabilities of the healthcare community and providers. To give you an example of how severe the shortage is of clinicians, yesterday, as I'm working from home and here in Illinois, I received an emergency alert on my phone. The same alert that you have with a nearby tornado or emergency disaster statewide. And it was a state communication that went out to any licensed clinician, begging the clinicians to come to the forefront and help with COVID-19 battle. And so again, we're seeing these shortages in not just the hotspots in the U.S., but also in other areas that have been traditionally underserved from the healthcare community. Looking now, age-based case fatality rate, we're not seeing a trend change in this picture. We're seeing still, by far and away, the elderly disproportionately impacted by COVID-19. Okay, and this I just wanted to quickly show you so that you understand it is not changing in terms of how it's impacting the community and why we're still very vigilant with trying to protect, in particular, our elderly from the younger population, which may have asymptomatic cases that can still transmit, as well as those who get mild disease. If we look at case fatality rates in comparison, this is a moderate comparison of what people have been kind of loosely saying, right? Oh, SARS is not as bad as the flu. Don't believe the hype. The SARS is worse. This SARS-CoV-2 is worse than the flu. If you look at seasonal flu case fatality rates based in the U.S. From 2018 to 2019, you're seeing 0.8% case fatality rates. Whereas this is data out of China on the right-hand side, you're seeing clearly up to a 6% in those 60 or older. All ages is 2.3% case fatality rate. So if anyone tries to fight you on this topic, just show them this stat and let them know it's definitely worse than the flu, no matter what anyone says. So when we talk about prevention, we want to just reiterate briefly here the curve that we showed last week. Again, social distancing being the epicenter of prevention with regard to limiting the number of individual contacts and strong distancing effects that this Stanford study has shown at 3 months of strong distancing, at 5 months of strong distancing. Again, the phraseology bend the curve is referring to this phenomenon, the curve of how many hospitalized individuals in the U.S. are we going to experience. 12,000 is the number at the top of this curve at 5 months in this particular model. And it doesn't get below a critical level, if you would, in that red zone, below the red line there, until we're 10 months out. With strong social distancing. So again, with all the learns that we've had from pandemics in the past, Spanish flu, we know that strong social distancing is going to continue to play a key role for perhaps months to come. And we'll talk about strategies to help prevent a recrudescence of disease when we're talking about getting people back into the work community here. So briefly, yeah, let's get into the work strategies again. We're going to look at mental health preventative strategies as well as some return to work strategies. So real quick, to reiterate what we talked about last week briefly, PTSD prevalent in the workplace, 5.7% during an individual's lifetime. In the US in particular, individuals will experience PTSD, right? And this is without pandemic size events. And we know that the job relatedness to PTSD with regard to injury has impacted the number of people that experience PTSD up to 44%. So we can only postulate that this pandemic, particularly with the impact to the ability to work or not work, and even encountering illness in the job place, as we're witnessing in the news with workers walking out of the workplace due to fear, right, and wanting more protection, it's going to impact the mental health status of folk, as well as have potentially long-lasting effects. And so getting ahead of that with strategies that help deal with stress is going to be key for employers in regards to keeping the workforce healthy and ready to come back to work when it's time. And so fear, so these are some of the signs and symptoms that is published. In this case, a lot of this comes from CDC, but looking at those things that help identify, are you dealing with a situation of shifted stress towards a level that needs to be addressed in a positive way, right? And fear and worry about your own health. Obviously, sleep abnormalities, eating abnormalities, chronic health problems worsening, right? We're seeing this now where people who have mild chronic conditions have a worsening of those symptoms, whether it be allergies, whether it be xanthoms of the like rashes of the skin, and et cetera. So those are all identifiers that people are maybe experiencing increased levels of stress due to not just the outbreak, but the impact to their basic livelihood. And as you identify these and being conscious of them, there are strategies that you've heard before, but we want to focus in on them quickly because they are important to helping decrease stress. Taking breaks from the news, from the media, it has been shown to decrease the amount of stress in individuals because it takes your mind off of the impact at a high level as well as an individual local level. Taking care of your body, always a good practice, but really deep breathing, some call it meditation, mindfulness. Those are all strategies that help. Eating well, healthy, well-balanced meals. One of them that we really pushed forward is exercise, and that plays a duplicative role, because exercise not only gets your body physically capable of dealing with stress with cortisol levels and whatnot, but it also releases endogenous opioids in the brain. And we know that that also helps deal with not just stress, but pain and how we experience those other stressors in life. And so these strategies are very key to individuals that are experiencing higher levels of stress to help them deal and cope. Unwind, obviously taking time to unwind and connecting with others through social media. We see even in our neighborhood in Chicago, our neighbors go out on the porch and we do the Facebook, singing songs, right, twice a week, right? So activities like that can play a role in helping individuals deal with the isolation and increased stress that we're seeing. When we talk about the mental health from the numbers standpoint, we are seeing increased numbers from organizations that are specific to helping solve and address mental health in the workplace and beyond, right? And so this particular article referenced what a company is experiencing that is doing telehealth for mental health plans, and they're seeing an increase of up to 25% greater utilization of their services for mental health. And they're seeing another company experience a 50% increase in activity since just the beginning of March. So we know that there is a substantial impact from COVID-19 on the stress level of our employees, as well as obviously the management and employers. So being mindful first and foremost of these increased stressors is key to identifying when help may be beneficial, intervention may be beneficial, so that we're better off in the long term here. When we talk about strategy, other strategies, we briefly mentioned some of the self-checking tools that are out there, from CDC to Google to things we're doing at WorkCare, as well as Blue Cross Blue Shield. The latest in this, just to update, has been Apple in conjunction with CDC launched a web app just last week. And so these tools are useful for helping decrease anxiety in certain cases, because it informs individuals of what may be factual and what may be fictional in regards to their own risk personally and others. So these tools, we do support their use to help in that regard. So as we talk about real quick and wrap down here, return to work strategies, we are very dogmatic around our philosophy of how we approach return to work. And it begins not just with the moment that somebody's out of work, but it begins while they are at work. Our philosophy is a return to work strategy begins from a daily touch with each worker and doing a screening, because the goal there is to keep healthy workers at work and sick individuals at home until they're ready to come back. And so a daily screening approach has been very efficacious for us to achieve that. And then next, risk stratification, where now if you're able to identify early on who may be experiencing symptoms that may warrant additional investigation, stratifying their risk individually is very important to proceed down this pathway towards return to work, right? And once they're risk stratified, particularly with regard to COVID-19, into a high, medium, and low risk stratification, then we're able to move on towards triaging them to the right care, getting them the right diagnosis, whether that's presumptive COVID or a person under investigation, whether they need testing, and we can do case management, meaning that there's a personal touch that's required to make sure that individual is progressing through their time at home if they've been quarantined or self-isolated. And we won't get into the details of each of the services that are out there, but there are services that are being developed by ourselves and by others to help with this management philosophy. But we want to introduce this philosophy first and foremost so that everyone can understand what are the best practices that are being propagated in the workplace to help manage with return to work. And then finally, the return to work piece is a determination that we'll talk further about in moments here. Just to reflect back real quick to some strategies that are at that daily screen level and what companies are doing, we want to touch upon that briefly again, because it's becoming ever more prevalent. And there are some issues that customers and employees are experiencing that we want to just reiterate, right? The false negative rates of these temperature thermometers, these infrared thermometers, can be up to 4 degrees plus or minus, right? So be mindful when you're purchasing them. Look at 3 things to look at, right? Look at the IR thermometer accuracy. That's the plus minus degrees. And try to find one that's +1 or -1 degree Fahrenheit. And they're available, not readily, but they're out there. Look at the consistency of measurement. And then finally, look at a ratio called the DS ratio, dot to spot ratio, meaning how far back can you be from the individual that you're trying to understand, trying to measure their temperature without increasing the unreliability of that temperature reading. So those are the three parameters we know to be very helpful with identifying a device that's more reliable versus a device that has significant limitations for this purpose. And the devices that are being used across the board almost are not FDA approved devices, right? They're not meant to measure human temperature. However, they're being used because that's what's only available. And one of our staff members actually spoke with the FDA yesterday and tried to understand what their level of testing of these devices is or is not. And their response was they are not testing these devices in any significant number moving forward because manufacturers are not coming to them for testing purposes, right? So to just speak to the actual risk of using the health risks and impacts to using these devices, it's virtually zero, right? If you have a device that is a classic infrared thermometer, it's nothing more than a camera in your smartphone that has a special lens that focuses infrared energy that's transmitted from anything with heat, including us. Humans, right? And so it's just focusing those bands of electromagnetic energy into a diode that then can measure the energy of that wavelength. And that is what helps detect the temperature of individuals. So the health risks are minimal to zero for impact. Now, there is some devices that have a laser pointer, and that laser pointer is what oftentimes gets demarcated as approved or not approved for human use in terms of shining it into people's eyes. So be mindful of that and what you're purchasing so that you're not buying devices that may have untoward effects, particularly from that laser pointer aspect of the devices. We'll kind of skip over the testing. The PCR testing right now, we know is fraught with false negatives. FDA says, even on their website, that clinicians should not rely on COVID testing alone to determine whether somebody has or does not have COVID-19. So I mentioned that briefly because the false negative rate of testing is 30%. 2 tests, 9%, 3 tests, 3%, because this is a critical step in the return to work. And if we look at return to work, the return to work that criteria that has been used anecdotally across many employers that we're seeing is a CDC recommendation of return to work, particularly the second bullet point here, that if you've not had symptoms for 72 hours, if you have experienced at least 7 days have passed since you first experienced your symptoms, then you may be in a position to return to work, right? The recommendations above that are a test-based strategy. Having 2 negative COVID-19 tests is what's required for the test-based strategy. And that's particularly if you've had laboratory testing to confirm your disease, right? And or presumptive in some cases as well. So with these 2 different pathways, we want to make sure that the workforce understands these were meant specifically for healthcare workers and not meant for the return to work process in non-healthcare workers like our employers deal with. And so if we look at specifically what the CDC recommends for employers and return to work, one of the bullet points here talks about returning to work should be in conjunction with best practices, right, with prevention, but also when we talk about work restrictions, I'll point out that when they talk about the healthcare workers coming back to work with the criteria we just mentioned, they also enforce that healthcare workers should wear a mask for a full 14 days, right? So again, this is not really applicable to the workforce returning to work because it's unlikely individuals are going to return with masks, donning masks on a daily basis for 14 days. So we want to look at specifically what CDC mentions. They mention that the return to work criteria should be met in consultation with healthcare providers, state and local health departments, right? And so that pathway does involve a clinical decision-making on who can and can return to work, and that's confounded with the evidence that shows just because you have a negative test doesn't mean you don't have COVID-19. 70% of people will have a negative test and be negative. 30% of people will have a negative test and still be positive, potentially. So again, as we talk about return to work strategies, we want to be mindful that we are including clinical expertise in some way, shape, or fashion to do that piece of it that still carries that burden of clinical decision making. So with that being said, we're going to stop there because we want to give a chance for some questions. I know we're already over time. We had a lot of material to get through, but we want to jump to questions real quick and get in as many as we can with the time we have.
Thank you, Dr. Harris. This is Karen O'Hara again. And I just want to remind everyone that we do answer all the questions in writing subsequent to the webinar, and we will distribute them through the next constant contact email that we'll be sending out for next week's session. We also post them on our website on the resources page, and we post a recording of the webinar on our YouTube channel, which is called WorkCare TV. So all 3 of the sessions recordings are going to be posted there now. The first 2 are already up, and the Q&As from the past 2 weeks are up on our website. So, Dr. Harris, we have a lot of questions about masks, which you didn't have time to go into, and what the current recommendations are for wearing them if you're asymptomatic. Can you clean them? What's the effectiveness of the different types of masks? So if you could just kind of give a brief overview of what the latest recommendations are for masks in general, not specific to the healthcare personnel population, but just in general use, personal use as well as workplace use.
Absolutely. So I'll be succinct in my response, hopefully here. We'll talk about 2 different types of masks: surgical masks and N95s. Those are the most popular in use. Surgical masks are not protective very much at all for the individual wearing the mask in regards to limiting the potential transmission to the individual of COVID-19. However, in regards to best practice with use of surgical masks, we do recommend it. Why? Because if you're able to get surgical masks in a quantity that allows your workforce to wear them and not mandated, but just wear them preferentially on a elective basis, it does and it is effective at limiting the droplets and spread of and transmission of COVID-19 potentially, because now individuals aren't spreading, even asymptomatic individuals, right, which is hard to control for or screen out, are now unable to effectively spread COVID-19 because their droplets are contained. So we do recommend, if you're able to use surgical masks in the workplace setting, particularly in those areas, and we've talked to employers that have job functions where social distancing is just frankly impractical to the operations. Those situations may be where you focus in on supplying these type of masks for that particular purpose to help protect those who are healthy and prevent them from becoming ill, because those who are ill have limited droplet spread. And then for the N95s, the biggest burden right now is, can you reuse them? The answer is yes. How do you reuse them? It's just simply, if they're unsoiled, meaning they're not frankly soiled by any means, then you're able to reuse them. And there is a process for cleaning them on a mass scale. A protocol has come out recently using peroxide. Now, doing this at an individual level, difficult, but those processes do exist to help with a broad approach to recycling these masks for organizations. So, and N95s can be used in a similar fashion to the surgical mask if they are the only thing available, particularly, again, those job functions where social distancing is impractical for operations.
Okay, thank you. The next couple questions are related to moving around and determining risk on a more local or regional basis. The first question is, what issues should be taken into consideration for a mobile workforce with crews that travel to various locations across state lines? Under the current circumstances, is such travel even advisable? The second related question is, shouldn't risk determinations be based on local communities instead of just the state? An example would be a rural community in Louisiana versus New Orleans.
Yes, the answer to the first question is it advisable for state, interstate travel? And that is going to be a case-by-case basis for the business case. You know, if you are an essential business and you need to keep operating and travel is part of that essential function, then it is, you know, obviously a situation where we want to do everything we can to protect workers, but that travel has to be based on the business case on an individual level. With regard to the risk association with state versus local, the answer is it's always good to look at the local scenario for risk. The tactic that we have used is to first start out with the state, look at, is there widespread disease, are there pockets? Both of those delineations are demarcated on the CDC website, and then secondarily going to the local health department as necessary if you do have individuals who are either under investigation or have symptoms that need to be risk stratified. So yes, local plays a significant role in determining risk.
Okay, we just have time for a couple more questions. We try to keep this to 30 minutes. It's impossible, but we have to cut off momentarily in the interest of everyone's time. But again, if you visit our website, www.workcare.com, you can find the answers to all your questions there. The next two questions are related to contagion, the period of contagion, whether people can get reinfected. We've addressed that reinfection question before, but people want to know if there's anything new about whether you get COVID more than once, and if any studies have showed how long after recovery people still are contagious.
Sure. The period of contagiousness, it precedes cessation of symptomatology typically. So people recover usually within 12 days after initial presentation if they have mild disease. Those individuals who are hospitalized have a longer, up to 3-week period of symptoms, as well as being contagious during that symptomatology. So the vast majority of people, once they've 72 hours after their last presentation of symptoms, are no longer contagious. And that is commensurate with the guidelines from CDC as well. And in regards to the reinfectiousness of SARS-CoV-2, no one actually knows yet whether or not the immunity to SARS-CoV-2 is lifelong. That is a question in the clinical community, and obviously time has not elapsed long enough for those studies to be performed. So over time, sure we're going to see that data come out. At this point, no one knows. It is widely accepted, though, that once you have particularly the immune cells, which is IgG and IgM immune cells that are tested for now in blood samples, once they're present to specifically SARS-CoV-2, then the widely accepted answer is no, you're not going to be reinfected. It's a low likelihood, if not almost, we've not seen it yet.
Okay, we'll have time for one last question, and then we'll let Dr. Harris go. And it relates to testing. Could you just briefly cover the value of testing, the current state of the tests that are available, and how you think testing in some countries compared to others has made a difference in the curve?
Sure. Testing is critical. And if we look at testing that has happened in the U.S. versus other countries, 2 weeks ago, I presented a graph, albeit 2 weeks ago. I think much has not changed in terms of testing per million of population. But the U.S., if you can recall, was right in the middle of that curve. Countries like Italy and other countries, China were higher on the number of tests performed. We see that obviously there's a number of factors that play a role in the severity and the mortality of SARS-CoV-2 with regard to populations, and there has not been particularly with Italy, right, that's high on the testing curve. They obviously have the highest case mortality rate too. So the testing does not necessarily correlate to better outcomes. However, the information we gather from testing allows us to see the total burden of disease in a particular geographic or population, and that allows us to then respond appropriately to next steps to help prevent continued spread. So it informs us of what other measures need to be taken, drastic or not, to help prevent spread. And the importance of testing with the return to work, we started to talk about today. Again, being able to test individuals to see if they've ever had an infection for SARS-CoV-2 is what's on the cusp of being widely done, right? And as these tests become more popular in the US, we do believe they're going to be used to return people safely to work and to school. If you look abroad, the type of tests that are available, there are tests that are rapid blood tests, a pinprick, just like you would with measuring your glucose, a diabetic would do with glucose. You can do with looking for the the IgM, the IgG immune cells, and they can give you results in as little as 10 to 15 seconds, right? But these type of tests have yet to be approved by the FDA, and we're not seeing them utilized as far as I can see yet in the US. Are they coming? Most likely. Abbott Labs announced yesterday, well, they didn't announce, but FDA announced approval of Abbott Labs rapid test. I'm sure everyone has seen that. So tests like these are coming to bear where they can give us results in the matter of minutes versus days. And they're going to be mediated by, I think, all the above, not just looking at immune cells, but also looking at still DNA material, or RNA material, genetic material of the SARS-CoV-2 virus.
Okay, well, that wraps up our session for today. I just want to thank everyone again for joining us for these very important webinars. We'll be doing the next one at the same time, same date, on Wednesday, 11 a.m. Pacific. And I just wanted to also mention that today we have an April Wellness newsletter coming out on managing acute stress response during the pandemic. So please keep an eye out for that. If you have any additional questions, feel free to send them to our moderator, Alexis Lupo, in response to other emails you've received from her. And we'll look forward to having you join us again next week. Thanks so much for your time today, and thank you, Dr. Harris, for your expertise. We really appreciate it.
Thanks, everyone. We'll see you next week. Take care and stay safe.